Hello everyone, in this video we're going to be discussing hypertensive disorders of pregnancy. We follow the SOGC guideline from 2022 on this one across Canada. Hypertension in pregnancy can be different than the regular adult population. Our diagnosis of hypertension is 140/90 or greater, and severe hypertension is 160/110 or greater. And both of these measurements should be based on at least two measurements taken at least 15 minutes apart on the same arm. As I mentioned, the SOGC guideline is the gold standard. You'll find that PDF of this document in your complex antepartum class if you do want to have a look at it. But I've sort of made a bit of a chart here on your screen, and it divides up the hypertensive disorders of pregnancy into chronic or pre-existing conditions, which means it's before 20 weeks gestation or preconception, so even before pregnancy. Gestational hypertension is first noted after 20 weeks gestation, and then preeclampsia we'll talk about. That's something that we're more concerned with. We have different terms for preeclampsia. We used to call it like regular preeclampsia or just preeclampsia and severe. However, now we've changed it to say it's either preeclampsia or preeclampsia that requires delivery. So just know if you're reading something that says preeclampsia that requires delivery, then you know it's more severe. Other hypertensive effects include transient hypertension, white coat syndrome, and masked, which I'm going to just show you here. Now you can see this is right from the guideline, and thinking about how we use these guidelines and how it's translated into your practice can be helpful. So you can read through the different types here. White coat may be something that you've heard about before. It's when people are in office and they have a high BP, but out of office it's lower. Something like a masked BP would be a lower BP, but then they have a higher BP when they leave. Proteinuria. We talked about this a little bit in the antenatal assessment class. It's either greater than 30 milligrams per millimole in a urinary sample or a random sample, or an albumin creatinine ratio of greater than 8, or 0.3 grams in a day when you're doing a 24-hour. Now, if it's a dipstick that you're doing, 1+ or greater is considered to be diagnostic for protein in the urine, and we use that when we're looking at whether or not someone has preeclampsia or not. So greater than 1+ is what the literature says. Just make sure you're kind of referring to your organizational policy and thinking big picture. So if you have someone with 1+ or 2+ plus other symptoms such as a BP of greater than 140/90, you're going to be suspecting preeclampsia, and you're going to want to report that promptly to the attending physician or care provider. So there's a few other things that happens with preeclampsia to make that diagnosis. So it's either the protein in the urine, so proteinuria, or sometimes we'll see more adverse conditions. So there may be maternal end organ complications or evidence of uteroplacental dysfunction. Sometimes these babies end up really quite small, or IUGR, intrauterine growth restriction, because of the hypertension and the decreased blood flow to the baby. So sometimes we'll see those end diastolic blood flow changes. Now, when we look at preeclampsia, as I mentioned, there's regular preeclampsia. We don't call it regular preeclampsia, we just call it preeclampsia, or preeclampsia that requires delivery. So there are situations where we'll do a C-section and we'll want that baby to be born right away, because often what happens with delivery of the placenta and the baby, the preeclampsia improves. Sometimes we do see postpartum preeclampsia as well. However, we're trying to prevent any further complications. So sometimes people with preeclampsia will progress to eclampsia, which is seizures, strokes, they're in a coma, and it can really, you can read on the screen here all of the sequelae that can happen with preeclampsia. So again, we want to just make sure that we're assessing blood pressure. We want to make sure that we're assessing for protein in the urine, whether it's a dipstick, a 24-hour collection, looking at urinary creatinine and or the albumin creatinine ratio. This is so important because this is a diagnosis that is associated with maternal death. When you look at hypertension on the list here, you can see the number of maternal deaths in Canada in 2017 was 42 related to hypertension, and that's about 1.2 per every 100,000 hospital deliveries. So when you look at, this is just another chart that I created from SOGC, because sometimes looking at the article can get a bit overwhelming. But again, you look at the potential adverse conditions and the severe complications that warrant delivery. So what we're trying to prevent is people getting to that eclampsia stage or having a seizure. The other complications are listed here. There's just a visual for you, and oliguria, so you'll see decreased urinary output. Cerebral disturbances are things like seeing floaters, having blurred vision, anything like that's concerning. Visual, anything like that's, sometimes they just all of a sudden see like double vision, things like that. Anything with the liver as well, so any pain to the liver, epigastric or right upper quadrant pain. You'll also sometimes see impaired liver function, thrombocytopenia, and pulmonary edema. As I mentioned, we're trying to prevent people from getting to eclampsia when we're caring for patients with preeclampsia, because this is when morbidity, mortality does increase greatly. As a rule, maternal and perinatal morbidity and mortality rates are highest when eclampsia is seen earlier in gestation. So if it's like 28 weeks or less, or when maternal age is 40 plus, if the person has had multiple pregnancies, and or if chronic hypertension, so pre-existing hypertension or renal disease is present. So that makes preeclampsia more risky. So knowing your patient's medical history is also very important. We're not really sure what causes preeclampsia. They think it could be abnormal prostaglandins, endothelial cell dysfunction, coagulation abnormalities. Dietary deficiencies or excesses have also been thought to play a role. It could be immunological as well. And sometimes people will have, two babies with a partner, and then they'll have a new partner, have another baby, and all of a sudden they develop this preeclampsia. So they think that maybe it's some kind of immune or autoimmune sort of function that's happening too. So they're not really sure why it happens. But when we look at actually what's happening with the patho, this is more of an FYI for you. You get the increased blood pressure, increased vasospasm, decreased placental perfusion, and then these endothelial cells are activated. And there's issues with vasoconstriction, of course, which is hypertension. It can cause those end diastolic blood flow changes in the placenta, which decreases blood flow to the fetus. You can get those IUGR, intrauterine growth restricted babies. And then you end up with an activation of the coagulation cascade, intravascular fluid redistribution, and potentially decreased organ perfusion. So again, when we're diagnosing preeclampsia, it's that high blood pressure, 140/90 with proteinuria or multi-organ involvement. This is not something that I want you to memorize, but this is sort of a nice overview because it provides an overview of all of the different risk factors. But the piece that I want you to pay attention to is really the yellow blocks at the bottom, because that's kind of what can actually happen as a result of preeclampsia. If patho is something that you're interested in, I thought this might be interesting for you to look at. From a nursing perspective, assessing the pregnant individual with hypertension, of course, we're going to do that perinatal history, taking their blood pressure, evaluating urine for output and protein, checking those neurological signs that we talked about, headache, blurred vision, floaters in their vision, assessing the head to toe, so thinking about what other signs and symptoms, so epigastric pain, right upper quadrant pain, and of course, we're going to be assessing the baby. Depending on the severity of preeclampsia, we may also be doing those biophysical profiles. So you remember we talked about that in the antenatal class when we're doing the ultrasound and measuring the criteria and possibly doing a non-stress test as well, and or a non-stress test. Sometimes we're doing only the NST. But if it's severe preeclampsia or we're concerned about the baby, you may see that biophysical. In terms of ongoing monitoring the pregnant patient, similar to what we've just described. However, there may be additional considerations. Edema, you will see pregnant patients with edema, peripheral edema, hands, feet, pedal edema, for example. If you see a patient with hypertension or preeclampsia with facial edema, that's a concerning sign. You may also see an increase in weight, changes in their labs, so hematocrit and platelets, which I'm going to talk to you about in a moment when I talk about HELP, which is a syndrome, and also liver function tests. Talk about HELP briefly. This is a form of the severe preeclampsia. So again, this would be probably that we're going to have to deliver the baby in these cases. These patients end up with hemolysis, which is the H, elevated liver enzymes, which is the EL, and low platelets. It can be difficult to diagnose because sometimes people think, oh, they have, gastro or the flu or gallbladder disease or hepatitis, because some of the signs and symptoms are the same. Feel like they have indigestion, nausea, vomiting, that headache, sometimes right upper quadrant pain, as I mentioned, changes in vision, swelling, which I mentioned earlier, of the face and hands, shortness of breath. If it's really severe, they're almost gasping for air as well. So these patients, usually we would deliver the baby. They may also require a blood transfusion. And if they're very premature, that below 40, or sorry, below 34 weeks, we'll give corticosteroids, and that is to improve fetal lung development. So to mature those lungs, and those babies often do a little bit better. I'm going to give you a practice question here. Mrs. Carell at 34 weeks gestation tells the perinatal nurse that she's been feeling fine. Assessment reveals a heart rate of 92, blood pressure of 140/92, and a urine dip of 2+. What further information would the nurse want to assess? Is it A, presence of headache, visual disturbances, and any epigastric pain? B, CNS urine results and temp? C, BP measurements in a supine position? D, stress levels at home and the patient's feelings about pregnancy. So the correct answer is A, presence of headache, visual disturbances, and any epigastric pain. B would be for infection. C, BP is not done lying down. And even though blood pressure, long-term stress, we know can affect blood pressure, in this case, that's not stress related. When we are caring for patients who have hypertensive disorders of pregnancy, we're not going to get into the medications in this class. Often you'll see antihypertensives during pregnancy, such as labetalol. For the prevention of eclampsia, though, it is important that you know that we give magnesium sulfate in labor, and this is to prevent eclamptic seizures and stroke. And so it really just calms everything down. Usually we would leave the lights low, limit visitors, really have a quiet space. And it's important to know that calcium gluconate is the antidote to magnesium sulfate. So if there is an overdose, an inadvertent or accidental overdose, and it's really important as well to do your independent double checks. We'll be doing blood work, deep tendon reflexes, and other assessments such as strict ins and outs as well, and a Foley catheter will likely be there. If you want information on antihypertensive medications, please do just have a look at the SOGC guideline. That's not something you're tested on for this class, but if you end up working in this area or have a particular interest in this topic, you can have a look there. In terms of prevention, this is something that we've been looking at preeclampsia for years and years. They thought maybe it was a deficiency in diet, such as calcium, vitamin D. Not a lot of really strong evidence, so they're kind of saying, this is the same as patients at increased risk for preeclampsia for vitamin D supplementation, calcium. Low dose ASA doesn't have a lot of strong evidence, but you may see that. Exercise is recommended, and of course, dietary advice. So that concludes our section on hypertensive disorders of pregnancy. And again, I think it's really important to have those take-home messages about preeclampsia and the signs and symptoms, because you could be working not in a maternity area and be seeing patients with this condition. So if you have any questions, let me know. Thank you.